early in the day to see such a technique, but the result is well worth it. I'm sure she'll be absolutely delighted. So now we're going to just move on to the non-surgical part of this. And you know, Rami did an excellent lecture as well, and we actually share a very similar kind of content. I guess because we're all operating in a very best practice kind of way. I'm going to show you the slight point of difference that I have here is related to not just the resting, but the dynamic component of the nose, because don't forget, although it is a static structure, it does have muscles attached to it, and those muscles are responsible for the generation of various different types of expression, and also the perception of various moods within a person, so we'll touch on that as well. So we've done that bit. Now let's look at morphology. We see all sorts of different noses every day because we're exposed to many different genetic influence, many different morphotypes, and that lends to different facial structure. Whether that be the piriform, whether it be the cartilages, the nasal bones, it means that everyone typically has a slightly different nose. Now, let's categorize them somewhat. Wayne Rooney, top left, he's got what they call as a snub nose. It means he's got like a little piggy nose, which is a little bit short and a little bit stout. So he's deficient in anterior projection. And then you have the Duchess nose. You see, she's got a beautiful nose, but with a slightly high, over-everted nasal tip. And then if you look at the Prince Philip and whoever that is next to him, is she a singer or something? I don't know. Bette Midler, Barbara Streisand, Bette Midler. They both look the same, don't they? So that's like a hawk nose. That's where you have a dramatic nasal tip descent with an A-list flame and a little bit of a snarl complex. Now Fabregas, the footballer on the right-hand side, he has like a Grecian nose with a extended nasopiltral angle. Tom Cruise is more of a Roman nose. And then you have the Nixon nose, which is very unique to him. And at the bottom right-hand corner, this is the cocaine nose. And this we're seeing an awful lot more in the Western world because of people abusing those kind of recreational drugs. So out of all of those people, who do you think has got the most beautiful? You know, this was a survey in the Daily Mirror, which is not the most scientific publication in the UK, but they voted that Carey Mulligan, this blonde lady here, has the most beautiful nose. And the reason why that is the case is because we're all hardwired to recognizing the geometrically perfect nose. It tends to be around these kind of angles, ratios and proportions. So the nasofacial angle should be 36, nasomental 130, and nasofrontal 120. You know, if we can create that in our patients with injections or surgery, we're going to make the nose the most optimum in terms of aesthetic that we can achieve. Don't underestimate the power of the Ricketts and Steiner's line. Means the relationship between the nose and the upper lip and the lower lip and the chin. The three of those things have a relationship with one another, which are all interchangeable, dependent on the position of the other one. In other words, if you push the lips forward and you don't bring the chin forward, they look too lip dominant. If you bring the chin forward, but not the lips look retruded, whilst the nose looks weak. If they're nasally dominant in a profile view, like we call it the hawk nose, you know, they look like an avian view with a projection of the nasal tip, you need to bring the lips and the chin forward to bring balance into the Ricketts and Steiner's line. And let's just talk about Ricketts line or E-line, which is the line which connects the nasal tip to the pagonian. That should form an anterior limit for the lips, whereby there should be an optimum distance from the line to the lower lip of 2 millimeters and the line to the upper lip of 4 millimeters. Now I'm giving you very specific instruction here because when you change the nose, and if you lift the tip, you need to adjust the lips and the chin as well in harmony. But look at the other aspects of geometry that we talked about before when I did the live assessment. The female nose, it should be the same width as her chin, which should be the same width as her intercanthal distance. Now the intercanthal distance doesn't change during your adult life. You die with the same one that you had when you were 21. And the nose will widen as we age. So does the chin. How do we make a widening nose narrow? It's so easy. You just put an injection of a medium strength HA filler onto the bone here at the piriform, typically around 0.3 cc. And as you tower up from the piriform and you give cephalic rotation of the nasal tip because of anterior projection of the alar domes, the pyramid becomes narrow. It's so cool. You can do it time and time again. I think we didn't do it in the live case, but maybe we will do it later on today. I don't know if we have the time. The other thing is that the thirds of the face, from the hairline to the glabella to the nasopharyngeal angle to the menton, should be equal thirds. During aging, the upper third becomes longer, the lower third becomes shorter. But what happens to the middle third? It gives a pseudo-elongation. And that's because of the dissociation of the upper and lower lateral cartilages and the upper lateral cartilage from the nasal bone, which gives elongation, but also because of loss of support at the nasal spine and the piriform, we see that the nasal tip starts to rotate down and descend, which gives a change in the light reflex, giving the impression of elongation. So how do we fix that? You inject the piriform, you inject at the nasal spine to give vertical elevation, and you inject in between the two columellar cartilages to give a Christmas tree kind of support to the apex of the columella, so that we drive the nasal tip upwards and cephalically rotate it like this. Aesthetic ideal for the male and female is different, so the rules apply for the nose to the intercanthal distance more for the female than they do for the male. Let's have a look at our supermodel again, and she's pretty damn good, but we can break it down a little bit more. There is the vertical fifth in the medial plane, intercanthal distance cutting right through the alar just perfectly and through her chin width. So she's AP view, she's perfect. Let's take a look at the thirds. Now then, look at how the middle third is more longer than the lower third. Let's explain why. When we drive these three injection points, which is largely based on light reflex, by the way, look at how there's a depression at the alar, and look how there's a depression at the supratip, and also the glabella. We see this much more clearly when we evaluate the side profile. So she has a glabellar protrusion with a dorsal hump and with a supratip depression. And that change in the light reflex, the disruption in light reflex, means that she would typically present with light, shade, that gives an illusion that the nose is longer. The minute you identify this and look at the anatomical plane for injection and you put it right, she becomes so much more beautiful. The importance of nasal width is kind of obvious when you look at parallels between faces that we know when they describe them as being twins. I know Natalie Portman pretty well, and she bears no resemblance to Keira Knightley. In fact, I think Keira Knightley is very unattractive when compared to Natalie. And look at the difference in the nose and the disruption of nasal width across from the nasal bridge right through to the alar width. You know, Keira Knightley is far too narrow, and she has that sort of Jacko kind of effect, which is very unattractive. So don't over-narrow these noses when you're injecting in the piriform, because you will distort the natural beauty of the face. When we age, and this is the same person, there's a great little documentary you can find on the internet, a video documentary of the same individual. You see alar splaying. You see the piriform dilating, and so the alar domes become slightly wider and a bit more snarly, and we have a little bit more of this kind of this increased curvature across the upper margin of the nostril. So why does it happen? Because look, as we age, the piriform becomes more open. So if right, let me just go back to the anatomy of aging for the skull. The skull becomes smaller as we age. We discussed that yesterday. But all of the facial foramina become larger. The orbit, the piriform, and also the oral aperture become larger as well. So if the piriform becomes wider, let's think about what happens to the nose. Well, the alar cartilages, the alar domes, are attached to the base of the piriform, and so it just follows it. So the nose becomes wider. The other thing that happens is that the nasal spine starts to become more retruded because of bony remodeling. So we see a good spine projection here, and look, you lose it. So if you lose your nasal spine, the columella starts to fall down into the hole upon which it sits. and then the nasal tip starts to droop. You know what that means for women? In your side profile, you start to look like a witch, and that's not attractive. Because what happens is, your nasal tip will start to descend, your chin will start to rotate, and you'll get a closed crescent formation in the lower thirds of the face. You can easily rectify this by injecting onto the nasal spine to give vertical elevation, and also the labiomental crease to push the chin down, and also into the apex to give stability and elongation. So we can fix all these problems, but we just need to understand the causality first. We looked at this already in terms of the differences of the nasal bone, upper lateral, lower lateral cartilages. All I would say is that these structures will dissociate during aging, so you will see natural divisions forming. When we use a cannula to dissect from the nasal tip up through here, you need to take care to gently pass through the little ligaments that exist at each of those junctions and not to force it, because it can be quite uncomfortable. The other thing to mention is that at this position here where you have the nasal valve, which regulates the flow of air on inspiration, if you overfill the patients, you'll give them nasal airway obstruction. Imagine how embarrassing that would be when you have to refer to an ENT surgeon. But the opposite can occur, which is really quite, I think, quite impressive. You know, the sportsmen that like to wear those sticky plasters on their noses when they're playing football or something? Well, the purpose of that is that the sticky plaster is like a little splint that wants to open up. And that opens the nasal valve and it facilitates better nasal airway. If we put a line of good viscosity HA filler across the nasal bridge, we give tenting and turgor to the nasal bridge, therefore we open up the airway. But if you put increased pressure at one point like here, you'll obstruct it. So take care to give even distribution when you're doing this kind of work. Let's talk about the dynamic part of the nose. How important do you think that the dynamic aspect of the nose is to expression? I bet you never really gave it much thought. Well, let me tell you something. It's of huge importance. Look at this aging image and tell me, does she look more sad during aging? Yeah. Does she look more tired? Yeah. But that's obvious. That's the easy part. Does she look angry, everybody? Why does she look angry? Because look, you can't see her glabella, so she's not frowning at you. What's she doing? She's snarling, right? And it's not nice to snarl at anybody, because only a dog should do that when it wants to attack you like this. So it's a vestigial human expression, really from the days when we were primitive, and when we needed to be aggressive towards our prey to catch them, or when we wanted to defend ourselves from predators to defend ourselves. So we shouldn't have this expression here. But why do we have it? Because when the piriform dilates, we see an openness here, and it allows more room for contraction for the perinasal muscles. Means LLS and LLSAN. They become more hyperdynamic. So therefore, when we see hyperactivity of this and also this muscle here, you start to snarl when you smile. And that means that you're trying to be happy to someone, but by the same token, you're also being aggressive. So there's a complete contradiction right there. So by stabilizing those muscles, you can make our patients look more serene and have more facial calmness. How do we do it? Well, first of all, we'd use Botox in the dynamic aspects of the nose, so transverse nasalis, here at the LLS, and also at the dilator naris, people that dilate when they smile, and also at the depressor nasi septi muscle. The dosages, by the way, are Allergan units, so if you use Mertz, it's the same. So let's have a look now at the snarl and see how that works. You know, we would increase the dosage relative to trying to reduce the hyperdynamic smile of the nose. So this is how it looks in terms of the Botox or the toxin usage, and that's the sequence in which I will treat the first 4 points. Let's now look at the volume issue, because if we have nasal tip descent and we have glabellar depression and we have a dorsal hump and protrusion, of the nasal spine, which causes closure of the nasal filtral angle, we need to use fillers. These are the points in which we inject the fillers. We start off with the piriform injection, then we place it onto the nasal spine for anterior projection. Then I will run a cannula from the nasal tip all the way up to the glabella to the radix point. Remember I just showed you on our 30-year-old model just now. The radix point means the cannula is inserted all the way up the nose until this point here, which is the horizontal line that's consistent with the base of the upper eyelashes, the upper tarsal fold. If you want to be meticulous about beauty, we need to pay attention to these kind of details. So, when you combine all of these things, you've got an 8-point rhinomodulation, and that's what I'm referring to, dealing with the resting and the dynamic parts of the nose. Now that's quite a lot of work, isn't it? Because, you know, typically, we do the first 4 points, we wait 2 weeks for the toxin to work, and then we'll do the structural stuff. You can achieve some beautiful results with cephalic rotation of the nasal tip. You know when you have a fleshy tip like this, which is slightly bulbous, you can sharpen it up. And also, she has quite dramatic hyperdynamicity of the dilator nares muscle, which quietens down beautifully. Dorsal humps can improve, and the nasal filtral angle can improve. Look also, you know, this is like a witch's kind of effect of the nose, where you have this little sharpening and tip descent, and that resolves. However, let's pay attention to the dynamic results that we achieve. Can you see that during kissing, the nasal tip rotates down because she has hyperactivity of the depressor nasi septi muscle, and now she has stability of the muscle because of the toxin use and also the myomodulatory effect of the filler. She has a much better stability of the nose on animation. And if we're going to get into very sophisticated results, this is the level at which we want to achieve the kind of endpoints with our patient. Supratip depressions are very common, not just in cocaine use, but also just in structure, and we can correct that very easily by using cannula. I don't use needles, by the way, in the lower part of the nose, because I think it's just too dangerous. Do you think she's beautiful? She's pretty hot. She's from Dubai, and she looks okay like this. Then she turns to the side, and I was like, oh my God. So you degrade when you turn your head from a 9 out of 10 to a 7 out of 10. So how easy is it to fix this person? You know, it takes only 0.1 or 0.2 cc of HA to fix that nose. So why wouldn't you do it as a mandatory treatment for her to get her to a 10 out of 10? Check this guy out from Stockholm in Sweden. What does his before photograph say to you about his current mood? He looks a little bit aggressive, right? Like he wants to do you some damage. And he's always been in relationships where he's kind of been the weaker one, and he said he wants to become stronger, more powerful, more respected. He wants to be the dangerous one, he told me actually. So look after the treatment, how the rhinomodulation makes him look calm, approachable, friendly, and less aggressive. Isn't it interesting? We're doing facial aesthetic work with injections, but we're changing the perception of the individual. I think it's phenomenal. In Asia, as Rami said, these noses are more challenging. In Asia, they have a flattened nasal bridge, and it needs more volume. Look at the amount of anterior projection I need to offer those East Asian patients. And that means that we have generated a vascular risk. Those blood vessels are everywhere, guys. So I challenge anyone to say, I know my anatomy, therefore I'm safe. You know, there's arteries all over the place. But it's about understanding where the key arteries are, and we've covered this already in detail. The branches of the facial artery, from the columella branches of the superior labial to the dorsal nasal and its branches. But irrespective of that, generally in the midline of the nose, particularly up into the upper third of the nose, there's no vessel. But as you come down towards the tip, it becomes more dangerous. Now, let's do an exercise, everyone. If you're wearing glasses, take them off. So, pinch the skin of your glabella and try and move it around. It's very loose, right? Now, come down to the dorsum and start to separate the skin from the cartilage, it becomes more difficult. As you come to the tip, I challenge you to try and separate that thick sebaceous skin from the nasal tip cartilage. It's virtually impossible. So doesn't it make sense that where you have loose tissue, it's much safer, and where you have medium tension, it's more dangerous, and where you have high tension tissue, it's increases the compression risk. You know, I've done a couple of noses where I was like, you know what? I did my best today. I'm happy with myself. Thank you very much. Off you go. And she's delighted. She comes back 6 to 8 hours later. Raj, I can just notice a change in the coloration of my tip because I put a little bit too much pressure into there. So you always need to respect that. I saw a lady from China. She got on a flight from Shanghai. She had a perfect rhino modulation when she was there. On the flight, she became necrotic because of the cabin pressure. So don't let them fly that day. In fact, don't let them out of the city that day. Give them your cell number and make sure they're okay for 24 hours, and then you're okay, you can be self-reassured. This is what happens. You can make an intravascular injection. If you use a very fine product, you know, it's like putting a very fine sugar into a very hot coffee. It disappears, and you may never hear about it again. But you want to put a thick product into the nose under high pressure with a high extrusion force in high volumes. You'll overcome the arterial blood pressure. The product will flow backwards against the vessel flow, and once you release that plunger, that stuff is going to go where the hell it wants to go, which means the eye, the forehead, and maybe if you backtracked it towards the mouth, you may affect the lip as well. This is what it looks like typically around the alar base. And if you do the tip, you know, this is going to scar and it's going to be a medical negligence claim against you. And God forbid you ever end up with a blind patient. So just as a word of safety, and I'll finish on this because it's not all good news, is it, Rami? You know, we're trying to, you know, we show a lot of sexy things and good results, but let's really not scare you, but ask you to exercise caution. Select a product which is soft enough to be safe, but hard enough to give a result. So that's up to you, okay? My personal choice, Juvederm Lift, Juvederm Voluma. Select low volumes for safety. Inject slowly, because slow injectors are safe injectors, and fast ones, they're dangerous. When I work with people in Korea and Taiwan, they push really hard. Sometimes the syringe is gone in a second, I don't even know where it went. If you're in the vessel, you're going to cause a problem. A low extrusion force, and also aspirate. You'll see me aspirate in dangerous sites all the time when I'm fixed. And of course, inject safe sites. Rami, you covered this beautifully, but I'm just going to summarize by saying, when you have a problem like this, do all of these things. Not necessarily in that order, just do them all. But inject hyaluronic days every hour in the first day, every day for the first week until you see a capillary refill improvement, because at this point, this is not an aesthetic patient. This is someone who you need to save her skin and save her face and probably her career. Thanks a lot, everyone.